Welcome. My name is Jenny Pagel-Guile, and I am the Executive Director. And on behalf of the National Pancreas Foundation, thank you for joining us today. You are part of our mission as we focus on our support and education to patients and their care providers. I'm excited that so many of you are able to join us, and those of you watching the recording. Our topic is nutritional approaches to support pancreas function and health. With a very special first guest, we will be speaking about the new NPF Cookbook, the Pancreas-Friendly Kitchen. I would like our author, Sally Sampson, to join us. A little bit about Sally. She is the founder and president of ChopChop Family Incorporated, publisher of ChopChop, the fun family cooking magazine for families. ChopChop's mission is to inspire and teach children and families to cook and eat real food together. Also, the author of the Pancreas-Friendly Kitchen. Sally and ChopChop is distributed in every state and 20 other countries, with a circulation that has grown to 4 million annually. Ms. Sampson is the author and co-author of many cookbooks, and she has contributed to the New York Times, Bon Appetit, Food and Wine, the Boston Globe, and Cooks Illustrated, among many others. So thank you so much, Sally, for joining us today to talk about the Pancreas-Friendly Kitchen, our new cookbook that is available for purchase online. But you have a personal connection with pancreatitis. Can you share a little bit about your experience with the disease?
My daughter, who is 31, was diagnosed with pancreatitis just after her first birthday. And I had never heard of pancreatitis. Most of the doctors that I was working with had never heard of pancreatitis. But when she was little, the thought at the time was that she should be on a 5% fat diet. And as a cookbook author and recipe developer, it was fairly easy for me to start developing recipes for her. But pretty quickly, the doctors thought that 5% was not the right number and sort of allowed for more. But so my background is as a cookbook writer. And so I really became interested in, well, really committed to feeding her properly. So she's now, as I said, 31. When she was starting at 1 year old, she was hospitalized about 10 times a year. Now it's closer to 1. But so, yes, it is very personal for me.
Well, thank you for sharing. I'm glad that her hospitalizations have gone down and she's maintaining health and definitely has a cook to go to for suggestions. So with the Pancreas-Friendly Kitchen Cookbook, we're excited to have this. It's available to order online. How did you get involved with the NPF and kind of start this project?
Again, when my daughter was very young, I didn't know anyone with pancreatitis. I'd really never heard of it. And so my doctor introduced me to Jane Holt, who was I think her title was executive director at that time of the National Pancreas Foundation. And so I got involved and, different people, diet and sort of what to eat were not really at the forefront. So more and more people were talking about it. And then I think we did the first version, I don't know, 5 years ago. Does that sound about right?
Around that time sounds right.
Yeah. So, we just continued to develop these recipes and make them better all the time.
Wonderful. And yes, Jane Holt's one of our co-founders, still very involved with the National Pancreas Foundation and continuing to lead the way with projects such as this. Are there any recipes in the book that are family favorites or something that's a go-to with your household?
They really all are. I mean, the most important thing to me is that the recipes taste good. If they're good for you and they don't taste great, you're not going to keep eating them. The absolute number one thing is that they taste good. They're all, my personal style of cooking, as well as developing recipes for ChopChop, is that things need to be simple. They need to be readily accessible. They need to be inexpensive. They need to be things that you will really make. And so, it's the pancreas-friendly kitchen, but it is really the friendly kitchen.
Wonderful. And so kind of along those lines, looking for what's easy, what's simple, And, you know, a lot of kind of the dietitian pieces with pancreatitis is you have to see what your body reacts to. Are there things that you suggest people to add flavor can start with? Or, you know, start with simple and then build for what their palate is? Or what are some ways that you can maybe change things up a little bit easily for the home chef?
I mean, I don't think this answer really is different for people who have pancreatic disease than for anyone else. I would start with what you like, you know, what's appealing to you. And, you know, if you don't like pasta, don't eat the pasta dishes, you know, but I also think it's worth going a little bit out of your comfort zone.
Wonderful. So kind of looking, you've mentioned your journey 31 years ago with your daughter. Looking at pancreatic care today and health now versus your experience, what would you say to other families, or what would be your tidbit of advice through your experiences?
Um, it's like a completely different world. It's a completely different world. 30 years ago, I don't think there would have been a call like this. You know, I mean, my daughter, you know, when she was little, never met a child who had pancreatitis. I don't think people were diagnosed as quickly. I don't think by a long shot as much was known. I mean, I think that when Lauren was little, it was like, well, you know, maybe this, maybe that. I mean, it really felt like no one knew anything. Whereas now, I mean, I'm still, even though she's 31, I'm still talking to pediatric pancreatologists because there's so much new information. And this is a horrible thing to say, but in a way, it's better to have pancreatitis now than when she was so little, because like, I know there's a camp for kids with pancreatitis. There's just so much information. I mean, there's more people in the world are talking about nutrition and also using food as medicine. That's not really a term I love, but I think in this case it really is. I just think it's overused, but it's night and day.
Wonderful, that's great. And yeah, you mentioned our Camp Hope. We host it for kids with pancreatitis. We have over 130 individuals with pancreatitis in one location, and they get to be a kid. And we have dietary restrictions. We've got a special menu for everyone, and nurses and doctors on staff. So it's come a long way in providing the adults that come back to volunteer say, you know, I wish there was something like this when I was a kid. So we're continuing to make a difference in that area and space, and continue to grow and learn and work with great partners such as yourself. So I appreciate you bringing the cookbook. And again, there'll be the QR codes on this screen. There's a link in the chat. But you know, kind of how does this tie into your work with ChopChop that you do on a daily basis as a recipe developer and the many projects that you're doing?
I'm sorry, can you repeat that?
I'm sorry, I was just asking how this kind of ties into your work with ChopChop, and your recipe development.
So ChopChop Family is a nonprofit that I founded, and we publish a cooking magazine for kids. And the idea is to get kids to be more responsible, and more connected to how they eat. So teaching kids to cook and to take responsibility, really. So if you have a child who has pancreatitis, I actually think, I mean, I think it's important for everybody, but I think that if you have a child who has any eating, any health/eating issues, teaching them to cook is so important because they begin to learn what they need to put in a dish, not put in a dish. I'll just tell a funny story, which was that when my daughter was young, we were at an event, a friend's party, and they offered Lauren, she wasn't standing next to me, a cookie, and Lauren said, no, I can't have high fat food. And the mother came up to me like, you're like psychotic, like your 3-year-old isn't, you know, like I'm so worried about weight. And I said, no, she can't eat high fat. But I actually think that was really important because even at 3, she really understood here food she can eat, here food she can't eat. And so I think cooking really teaches you that. And so if you're a child and you're making something and it says ground beef, there's no reason a 5-year-old or a 10-year-old can't say, oh, maybe ground turkey would be a better option here. So that's what we do at ChopChop, but I really think everybody should be doing that.
That's wonderful. And it's a perfect example. And the kids really do look at that menu at Camp Hope. What can I have? What's celiac? What's,
Right.
the option? So it's really great to see them take ownership and have, awareness of their condition and how they can help advocate for their own health, and food is such an important part of that. So thank you so very much, and we appreciate you taking time today to speak to our group. Is there anything else that you'd like to share, or anything else that you thought was a great experience with the Pancreas-Friendly Kitchen now that it's out?
Well, actually, one thing that I will say is my daughter is not on any medication. She is not as sick as she used to be as a child, and she does really watch what she eats. So I think that I'm not saying you shouldn't be on medication, but I think diet for many people, not for everybody, really makes a difference.
Wonderful. Well, thank you so much for your time today and sharing this, and sharing your journey and how that interrelates to this great product that we have, and then we're sharing it with our centers of excellence. And again, there's some sample recipes on our website, and then you can order the cookbook as well. So thank you so much for your time today, Sally. To our next speaker, Dr. Anna Evans Phillips is an assistant professor in the Department of Medicine to the Division of Gastroenterology, Hepatology, and Nutrition at the University of Pittsburgh, Pennsylvania. She graduated from the University of Pittsburgh School of Medicine and completed training at Yale, Columbia, and the University of Pittsburgh for a residency, GI fellowship, and medical pancreatology fellowship. She is a medical pancreatologist whose research focuses on nutrition and pain in both acute and chronic pancreatitis. Her research is funded by the National Institute of Diabetes, Digestive, and Kidney Disease, and she is part of several NIH-funded national consortia investigating pancreatic disease, as well as the International Pancreatic Pain Consortium, a group of collaborators around the world who are investigating causes and of treatments of the pancreatic pain. I'm now going to turn it over to Dr. Phillips. Thank you so much for joining us.
It's really my pleasure. Thank you so much, Jenny, and to the National Pancreas Foundation for inviting me to speak today, and welcome to all the participants of today's webinar. And so I'm going to just take a brief moment here and do a short presentation on nutritional approaches to support pancreatic function and health. I am a medical pancreatologist here at the University of Pittsburgh, and again, I'm thrilled to talk about this topic. It's of great import to our patients with pancreatic disease of all kinds. And so this is just a short talk. Actually, it really just touches the surface here. And so I had a little bit of a peek at some of the registration questions about nutritional issues in pancreatic disease. And so I've tried to address some of those here. But of course, towards the end of the session, I understand there may be time for more questions. So we'll look forward to answering some of those from the Q&A. And so I have no financial disclosures. The only thing, again, that I would highlight is that this information comes from the perspective of being a medical pancreatologist. And I am a medical pancreatologist for adult patients. And so for those of you who are looking for answers about pediatric pancreatology, there may be somebody who's better suited to that, since most of the patients I see are 18 or older. A few caveats also related to the information that I'll show here, and those are that first, each person's nutritional situation is quite unique, and so this presentation does not, unfortunately, replace any physician, nursing, dietitian, or nutritionist recommendations for any individual's unique situation. Those definitely need to come first. And I always recommend talking with a pancreatologist or a gastroenterologist with interest in pancreatic disease directly about any nutritional recommendations that might help to optimize an individual plan for great nutrition. So first and foremost, the foundation of a healthy pancreas and the best way to support a pancreas is maintaining a healthy lifestyle as much as possible. And just in the interest of starting everybody off on the same page, the recommendations that would come from healthcare in general would include the basic tenets of a healthy lifestyle. And those might include things like maintaining a healthy weight, a body mass index of somewhere between 18 and 25, which is cited as normal. Abstinence from tobacco, which has been shown multiple times in the research, to have a dose-dependent and toxic effect on the pancreas and can progress pancreatic disease over time. limiting of alcohol or even abstinence from alcohol in the setting where alcohol may have had a negative impact on the pancreas so far. And then a balanced diet, which I'm sure you'll hear a lot more about in the coming minutes. But this would include things like 4 to 5 servings of fruits and vegetables daily, a diet that would be low in fat, and limiting things like processed foods. Now, the pancreas is a single gland, but a gland that has 2 distinct functions. Those functions are endocrine first. And so what you see on the left are cells in the pancreas that make insulin, glucagon, and other hormones that help to regulate blood glucose levels. And then there's an exocrine function. And this refers to the diagram that you see on the right, where acinar cells in the pancreas, which are the majority of cells that make up the rest of the gland, create digestive enzymes that break down protein and fat. Now, things that I might see commonly in my pancreatology practice, although they may not be common diseases in the population, include acute pancreatitis, which is one of the most common GI diagnoses for hospital admission in the US. Chronic pancreatitis, which itself is a rare disease, but which we see quite a bit at our Pancreas Center of Excellence on a referral basis. And then pancreatic cancer, which sadly, is one of the leading causes of cancer death in the US and is a very tough diagnosis. The most common type of this is pancreatic ductal adenocarcinoma, which is, topic for a totally separate webinar. But patients who have had surgery for either benign or malignant pancreatic disease, are regularly seen in our practice as well. Now, I'll be talking mostly from the perspective of patients, who have been affected with one of the first 3 there. Other conditions that might, be seen in our pancreas are patients who have, situations where they have fatty replacement of the pancreas, which is a diagnosis of unclear clinical significance, I would say, at this point in time, just given that there is a lot of ongoing research on this topic, but it's not clear how or how frequently this affects the population in general. And then things like cystic fibrosis, which is a well-described diagnosis, but something that is often managed by a multidisciplinary team of pulmonologists and gastroenterologists, and which is a little outside the scope of this presentation. And so in the instance of any of those first 3 diagnoses, and for other, related conditions or sequelae of those conditions, dysfunction of the exocrine pancreas is the main situation in which we start to talk about nutritional considerations related to the pancreas. So the pancreas, when it's healthy, has a large secretory capacity. About 1.5 to 2 liters a day are, the volume of material that's coming out of the pancreas. And that's usually a combination of sodium bicarbonate and enzymes that will digest fat and protein and complex carbohydrates. These are called amylase, lipase, and protease. And as some of you may be familiar with, these are components of medications that can be used to supplement pancreatic enzymes. Now, individuals who lose what is called the exocrine capability of their pancreas tend to have difficulty digesting and absorbing fat and protein. And so exocrine pancreatic insufficiency is a syndrome that occurs secondary to the loss of the ability to digest fat and protein. And we'll talk about this a little bit more. Now, the loss of pancreatic function mainly occurs where there is damage to the pancreas. And this can happen in settings where it occurs gradually after multiple episodes of acute inflammation, such as might occur in acute pancreatitis. It can happen quickly after a very severe episode of inflammation in the pancreas. Following surgery, such as might happen for cysts or tumors of the pancreas, where part or all of the pancreas may be removed. And here, some patients do actually undergo complete removal of the pancreas, which is very rarely performed, but is necessary in some situations in order to treat the disease. And so as a consequence of scarring, destruction, or surgery, where part or all of the pancreas may be removed, the pancreas can lose the ability to perform either the endocrine function or the exocrine function of the pancreas. And so what can result are situations where patients may develop diabetes, which is, again, topic for a totally separate webinar, or they can develop exocrine pancreatic insufficiency, which we'll, again, talk a little bit more about. Now, this is a disorder of the exocrine pancreas, and it refers again to the failure of the pancreas to deliver what would be a minimum threshold level of enzymes, specific enzymes that are necessary to digest things in the intestine. Consequences of this phenomenon include maldigestion of nutrients, so basic calories that are necessary to sustain weight and energy and activity level, and then also macronutrients, things like vitamin levels and nutrients, minerals that are necessary for patients to live healthfully. Now, these deficiencies in vitamins and minerals we'll again talk about a little bit more in depth in just a moment. But exocrine pancreatic insufficiency, this diagnosis, most often it is clearest in the setting of late-stage chronic pancreatitis, where there has been a great deal of destruction to the gland itself, over 90% of the gland having been destroyed, in a very severe setting. And this is the way it has long been described and perceived by pancreatologists. But I will say that we are developing a much more nuanced understanding of that these days. And so there's a kind of new openness to the fact that the degree of dysfunction of the pancreas may more significantly parallel the degree of fibrosis in the gland. And there may be other reasons actually for the gland to not be performing as healthfully as it may once have. One of the very big caveats that we have though at the current time is that we have limited tools available to assess exocrine pancreatic insufficiency prior to its very late stages, where it becomes exceedingly clear to both patient and provider that there is a problem. And so, that's something that we can talk more about in depth, but I would say that that's a major limitation in the field at the current time. Manifestations of very clear exocrine pancreatic insufficiency, though, include weight loss, steatorrhea, which is a fatty diarrhea due to that inability of the body to digest fats, and so they pass straight through the digestive system. And patients can develop fat-soluble vitamin deficiencies, which can be very severe. Now, treatment for this, as we'll come to in a moment, includes pancreatic enzyme replacement therapy, which is the most common way to treat this disorder. Now, just last year, actually, there was a very nice review of clinical recommendations, actually, on how to approach exocrine pancreatic insufficiency for providers. And so many gastroenterologists or primary care doctors who have an interest in exocrine pancreatic insufficiency may already be familiar with this diagram that comes from that article. But broadly speaking, what this schematic is showing us is essentially outlining for providers how to think about this diagnosis, conditions in which to really suspect exocrine pancreatic insufficiency very strongly versus other situations in which to consider that as part of a differential diagnosis. Then how to diagnose exocrine pancreatic insufficiency, what tests may be helpful in making that diagnosis, and some of the caveats, to those tests. Then, importantly, how to manage exocrine pancreatic insufficiency in those patients where it is diagnosed. And then lastly, the things that are important to keep in mind as treatment is pursued, including what the outcomes really are meant to be. The goal overall is to improve quality of life by controlling symptoms of this disorder and reducing complications and long-term sequelae of untreated exocrine insufficiency. Now, with that, I wanted to highlight a test that is commonly used to diagnose exocrine insufficiency, and that is fecal elastase, or FE1. And so fecal elastase is broadly available, across healthcare centers in the US at this point. It has been widely disseminated, and this is frequently used to diagnose this disorder. Some of the main reasons that is the case is that it is easy to perform, it is straightforward for the patient and the provider, and it can be done, as an inpatient in the hospital if someone is admitted, where they can have, a stool sample done and then transported to the lab, or they can provide a stool sample at home if they're doing this as an outpatient. And a severely low result provides clear diagnostic information in the right clinical setting. Now, two of the major cons, though, of this test are that there is a very poor correlation between fecal elastase and the gold standard for diagnosing exocrine pancreatic insufficiency, which is a coefficient of fat absorption, which requires a 72-hour stool collection. And so if one reads between the lines there, that is a real extreme test to undergo, and very few patients are excited about doing that. And so not only is there a poor correlation between fecal elastase and what is called the CFA, but also a low value of fecal elastase can result from any cause of diarrhea. And so that's a very important thing for both patients and providers to keep in mind when the test is sent off. Just that, unfortunately, patients, if it's not done in the correct clinical setting, and there may be another reason for them to have a low fecal elastase, it can give a false positive. And so not all low fecal elastase levels are indicative of a true pancreatic problem. In the correct clinical setting, it may be diagnostic, and it can certainly give important information, but it's not something that isn't without potential false positives. And so with that in mind, again, I'll highlight here, the most common scenario in which exocrine pancreatic insufficiency and its complications are to be considered. And that's in the setting of the disease of chronic pancreatitis, which is a fibroinflammatory disease of the pancreas and a result of inflammation that tends to not heal or improve. This indicates permanent damage to the gland that can manifest with chronic pain, inability to make digestive enzymes, and failure of the pancreas to control blood glucose. And so in this disease process, exocrine pancreatic insufficiency, again, this is the most common place that we might see that. Now, why is exocrine pancreatic insufficiency a diagnosis of such great import in this, in this arena? That is because when it's left untreated, it can lead to some very difficult to treat complications. And so it can include things like sarcopenia, which is a syndrome of the loss of skeletal muscle mass or loss of strength. And it can be associated with decreased quality of life, increased hospitalizations, and decreased survival. It can also result in vitamin and mineral deficiencies, which can be very difficult to treat. And so in chronic pancreatitis, this is a recent publication actually that showed the percentage of chronic pancreatitis patients in a specific cohort that were affected by these deficiencies. And so you see here that it's not the majority of patients, but these do occur, and it's important to keep a low threshold for investigating these possibilities in the right clinical setting. And so we have long been concerned about exocrine pancreatic insufficiency in chronic pancreatitis, and certainly in situations where part or all of the pancreas has been removed. Acute pancreatitis is an arena, though, where we had less frequently thought about it until very recently. And so, we actually had just recently published a study, which was a prospective study looking at patients with acute pancreatitis. And what was found is that about a third of patients still had evidence of exocrine pancreatic insufficiency after acute pancreatitis at 12 months following their attack. Now, this goes with the caveat that the diagnosis of exocrine pancreatic insufficiency in this study was made by fecal elastase with the caveats that I just mentioned. But an important finding is that, again, about a third of patients were still affected about a year afterward. And so this diagram here, what it shows is the rather natural history, if you will, of exocrine pancreatic insufficiency following acute pancreatitis. And in blue, what is described are patients who have no evidence of insufficiency. And in orange are those who do. What you see is that there is some crossover between the groups, but still at 12 months after their acute pancreatitis attack, all the way over on the right, again, about 1/3 of patients are affected, with a low fecal elastase. And so important to remember just that, there are situations in which exocrine pancreatic insufficiency still must be considered as a diagnosis, even where the pancreas otherwise seems to have recovered. And so treatment of this disorder is pancreatic enzyme replacement therapy, which includes exogenous enzyme capsules containing lipase, protease, and amylase, the three major enzymes that are produced by the exocrine pancreas. Aims of this therapy are to restore intestinal lipase levels, compensate for deficiencies in endogenous pancreatic enzyme secretion, correction of maldigestion and malabsorption, and improvement in symptoms that result from the loss of pancreatic exocrine function. Now, I had noted that a couple of participants in today's webinar had asked about dosing of pancreatic enzyme replacement therapy. And typically, from a pancreatology perspective, what we recommend is included here, where a starting dose would be 500 units of lipase per kilogram per meal. So an example calculation for an 80 kilogram would be 40,000 units of lipase. And then a smaller dose, about half of that, for a snack. And so those doses, though, should be titrated in order to reduce the fatty diarrhea that might come with this diagnosis or GI symptoms of maldigestion. There is a maximal dose. Very rarely do patients reach that, but it should be known that it is titratable, to symptoms, and that whatever level it requires to reduce symptoms is the correct dose for that patient. Now, there are 5 oral types of pancreatic enzyme replacement therapy on the market at the current time, as well as 1 inline lipase cartridge. And so I raise this only because I would want patients to be aware that there are different options in terms of obtaining prescription therapy, pancreatic enzyme replacements. That one may be more helpful than another, although in research studies the activity has been shown to be comparable in all of them. And so important just to know that there are more than one option. Tolerance of pancreatic enzymes generally tends to be very good. There are a few side effects of these medications. Things that are most commonly described, though, include constipation, where most frequently actually patients are perceiving constipation where their bowel movements have been restored and fatty diarrhea has gone away. These medications are porcine derived, and so patients who have a true pork allergy unfortunately are limited in their ability to take these medications. Some religious concerns have been cited as well, but know that many religious figures have actually noted an exception for essential medications in this situation, and so something for individuals to be aware of, to contact their religious organizations if they have concerns about that. Fibrosing colonopathy is a very rare disorder that occurs most commonly in the setting of very, very high doses of pancreatic enzymes, and has been described only a few times in the literature. And then gout flares are uncommon, but can happen in patients who are affected by gout just because PERT helps break down protein. Now, I wanted to come back just kind of full circle actually to healthy eating practices. Again, just highlighting some of the questions from the registration listing were questions about healthy eating and fat content of diet, which are quite frequent in this arena. And so I wanted to highlight the CDC's actually healthy weight guidelines and healthy eating recommendations. These dietary guidelines, are very broad, but cover a lot of material for individual situations. And I think, quite nicely highlight different strategies for targeting good dietary practices, especially as people are trying to make modifications to their diet. And so that's, one resource that I often recommend to patients in terms of places to look for food information. Then just briefly, I wanted to highlight a couple of concerns that people often cite about vitamin and mineral levels. And so fat-soluble vitamins, are one of the deficiencies, as I mentioned before, that can result from untreated exocrine pancreatic insufficiency. And so fat-soluble vitamins have to be accompanied by a digested fat to be absorbed. And so low levels of fat-soluble vitamins and minerals can lead to further complications that are easily avoidable with adequate supplementation. And so I tend to recommend in patients who are affected by exocrine pancreatic insufficiency, annual monitoring of these levels under the guidance of a healthcare provider. Lastly, I just wanted to highlight, some principles of a low-fat diet. And so again, we get a lot of questions about what is meant by a low-fat diet, since oftentimes in response to a new diagnosis of pancreatitis, either acute or chronic, patients are counseled to follow low-fat diet. And so a low-fat food is one that we would think of as a general rule of thumb. It provides 100 calories and has less than or equal to 3 grams of fat. And a low-fat diet is a diet where approximately 30% or less of the calories might come from fat. And so for many individuals, this can lead to a lot more reading of nutrition labels, which initially can be frustrating, but leads to, kind of an amazing health literacy when it comes to trying to translate, from a package what is actually the health value of a food that you might consume. And so some examples of low-fat foods, are listed here just as people are considering what kinds of things to add to their diet. These would be things that are generally recommended. And so brief conclusions from this portion of today's webinar would just be a couple of take-home points, including that the cornerstone of nutrition in pancreatic health includes things like a balanced diet, healthy lifestyle, and healthy weight. Diagnosis of exocrine pancreatic insufficiency, as you've seen, can certainly be challenging, but it's not impossible. Pancreatic enzyme replacement therapy supplementation is not an exact science yet. However, it is not only useful in exocrine pancreatic insufficiency, but it can be useful in other clinical scenarios where fat malabsorption is suspected. And lastly, a lot of work remains to be done, to improve our diagnostic process for exocrine pancreatic insufficiency, developing, better ways to supplement with pancreatic enzymes, including synthetic alternatives, and treating of fat malabsorption. And so I'd like to say thank you. And again, thank you to the National Pancreas Foundation, Jenny, and the organizers for the opportunity to present today. And I'm going to start just by reading out some of the questions in the Q&A so that way people know where we're starting and where we're headed. And so starting relatively from the top, there's a question actually about the concept of good fat versus bad fat in the context of chronic pancreatitis and exocrine pancreatic insufficiency. And so here, I will say that there is ongoing research actually about different types of fat, saturated, unsaturated, the degree of different chemical properties in specific dietary fats, essential fatty acids, etc. What I would say is that one of the very important things about taking in fat despite a diagnosis of exocrine pancreatic insufficiency or chronic pancreatitis is that you would need some in order to be able to digest and absorb fat-soluble vitamins, which are essential for healthy living. And so I think therein lies, part of the import of taking pancreatic enzyme replacements, if that is feasible for a patient. And yet that's important to balance that with the potential complication of taking in too much fat or triggering symptoms of chronic pancreatitis. As part of the foundation for what we often will counsel patients to, we recommend a low-fat diet pretty frequently, in patients who have either recurrent acute or chronic pancreatitis or patients who suffer from exocrine insufficiency. And, part of that is that the presence of fat in the stomach certainly triggers the pancreas to secrete more enzymes to try and help digest that. And so the theoretical idea of that is that, a lower fat diet will allow the pancreas to, not be required to secrete as many enzymes and therefore, allow for easier digestion of those food contents overall. And so, again, I will say that it's not an exact science, but it's an important tenet of, kind of health for patients with pancreatic disease, and is something that, has been borne out in experience and research to show that patients do better, on a low-fat diet. And so moving forward from there, a couple of additional questions. There's one actually about, total pancreatectomy, which might be a little bit outside the nutritional aspects of this particular webinar, but something certainly that, is a procedure that is more and more commonly performed these days, but I will say is recognized as something that is at one end of the spectrum in terms of surgical intervention, and it's important to feel comfortable with the plan moving forward, and if there are questions about that, then obtaining additional opinions from other specialists might be helpful. And I think through there, the National Pancreas Foundation certainly has a list of pancreas centers of excellence, that can be contacted as needed. Now, again, moving forward, so questions about exocrine pancreatic insufficiency and pancreatitis diet. I would say those are two different two different terms that would be defined separately. Exocrine pancreatic insufficiency, as I mentioned in my talk, is a syndrome diagnosed, that indicates a low level of pancreatic enzymes that are being secreted by an organ that's unable to secrete as many as it otherwise would in a good health condition. A pancreatitis diet, of course, is something recommended by healthcare provider to try and accommodate the needs of a patient who may be affected with pancreatitis. A couple of questions actually about meals that are generally okay for pancreas patients. And so here, things that I would say are that talking to a nutritionist in conjunction with a healthcare provider can be very helpful. As Jenny had outlined, there's a longstanding pancreatitis cookbook that has been present in addition to the new project that's been made available, where there are suggestions about meals for patients. But those rules of thumb that I mentioned in my talk about a low-fat diet being less than 30% of calories coming from fat is generally what would be recommended. A question about gallbladder removal after acute pancreatitis. Now, gallbladders hold bile. They're a repository for bile, and so that is separate as an agent that can help to digest fat. In many patients, complications after gallbladder removal can include development of diarrhea, and that's something that should be investigated further again with a healthcare provider, just because that does end up being a separate issue, but it could be a separate cause of diarrhea and not indicative actually of any problem with the pancreas. A specific question that we get a lot actually about non-alcoholic beer versus alcoholic beer, and what I would say, is that there's no safe level of alcohol that can be recommended, and so that's kind of where the discussion has to stop at this point in time until additional research is done about certain thresholds. But there's just no safe level that can be recommended to patients, which is often what I will answer to that question in clinic. Amount of protein for patients with pancreatitis. There are many recommendations about a low-fat diet for patients. I would say protein is a very important component of the diet in order to maintain muscle mass. And so usually you will not hear a low-protein diet recommended, given that patients require a certain amount of protein to maintain the degree of muscle mass that they have. The amount of fat that is in a diet can have, if it is very high, can have a lot of extenuating, or a lot of negative sequelae. However, a diet that is high in protein is unlikely to trigger an attack of pancreatitis, unlike a diet high in fat. Then a couple of other questions actually about well, there was one specific one actually that came through in the chat actually about ideas for patients with pancreatic disease who are unable to tolerate pancreatic enzymes due to a true severe pork allergy. And for those patients, that's a very challenging situation. And at the current time, what I would say is that we really have, very few options, especially to supplement pancreatic enzymes. There are efforts underway to work on synthetic enzymes, but what I can say is that this is a slow process, and drug development takes a very long time. And so in the interim, very important things to do for patients who are unable to tolerate pancreatic enzymes include, careful monitoring actually of vitamin and mineral levels to detect any deficiencies that may be present in the setting of malabsorption, and adequate supplementation by whatever means are feasible in order to maintain those levels and therefore support health as much as possible. A question actually about recombinant DNA technology and human pancreatic enzymes not having been developed. Again, I think I would echo there, the fact that drug development is a slow and careful process, and so this is something that I'm sure is a topic of interest for researchers out there, but may not have been, moved to a stage where things can be made available to patients. Another question that we get a lot, actually, and I see here in the Q&A about over-the-counter pancreatic enzymes or non-prescription pancreatic enzyme supplementation. And what I would say, unfortunately, is that non-prescription pancreatic enzyme supplementation falls into a category that is less heavily regulated by the Food and Drug Administration. And so, unfortunately, those products in research studies have not been shown to date to have enzyme activity in the same degree that prescription enzymes do have. And so they unfortunately can't be routinely recommended as a viable alternative to prescription pancreatic enzyme replacement therapies. While they may be effective for some patients, and like I said, unfortunately, we've not been able to show that they have any similar activity to those that are made available by prescription. And so a couple of additional questions about gram amounts of fat that can be eaten in a given meal and thresholds, so forth, both fat and sugar. Again, I would return to the rules of thumb. This is not an exact science, and so there are things to target. What I would routinely recommend to patients is, again, making sure that less than 30% of calories are coming from fat in a meal, and you want to try and make it as close to that individual rule of 3 grams of fat per 100 calories, kind of threshold as well. But I think the things that I generally will do with patients are go through their meal plans for a week, for example, or go through a food diary from a prior week and help them to identify foods that, may have been triggers for them for certain symptoms. And I'll encourage them to do some of that examination of their own dietary patterns in order to identify things that could be problematic. As Sally made the excellent point before, food is part of the fabric of our everyday lives. And so this is a really intimate and important topic for people. It really ties into quality of life and is something that is of great import. And so I also encourage patients to have an open mind about, how they may think about food indulgences and family gatherings and foods that they can share with other people, in order to try out things that they might not have done before, to kind of open all available avenues, even though there may be certain things that are restricted to them because of their health needs. I think, let's see, a couple of other questions that have come in. One specific one actually about patients who are diagnosed with pancreatitis and meeting with our registered dietitian. That's a great question to ask about what questions should one ask to a registered dietitian. Certainly coming in and having an open, blank slate conversation can be pretty hard, but I think you could start with the level of detail that you would need to know. For example, here's what I normally eat in a week, have a new diagnosis, and how would you suggest I change this to accommodate my new restrictions related to this diagnosis? Or can you help me develop 3 or 4 meals that would be realistic for me, to try out over the next week to make sure that they go okay? Something like that is a small, kind of bite-sized conversation that can then be had in the time of an appointment. Let's see. Additional questions that have come through. A follow-up question to the question about good or bad fat. I think, in a broader sense, the question of good and bad fat and a lot of health information that you might see online or health information that might come through via various sources. I think it's important to filter it through that individual's specific needs. And what I mean by that is just that health information and a judgment related to a specific food or a specific set of foods might be being relayed with different priorities in mind. As I alluded to at the beginning of the talk that I gave, acute pancreatitis is a diagnosis that lands a lot of people in the hospital. We see a lot of that as gastroenterologists, and yet, it's not something that people see or experience frequently, or even, that the majority of people would experience during their lives. Chronic pancreatitis is a relatively rare disease. Pancreatic cancer, unfortunately, affects, somewhere around 1% of the population over the course of their lives. And so, what I would say is just that pancreatic disease is not necessarily the dominant filter for much of the health information that is relayed online or in other avenues. And so I think it's, it's an important thing. And all of you here, are seeking information from a place like the National Pancreas Foundation, which really is doing its best to, relay health information of high quality to, to interested individuals. And so I think I would just relay that that's a great start actually for looking for reliable health information for specific conditions related to the pancreas. Let's see, a couple of other questions that came through. There was a question about finding local dietitians and so forth. And so here, I think you could be back in touch with the National Pancreas Foundation about the network that they have of pancreas centers of excellence, in terms of being able to find providers in the area that could have some, helpful conversations with individuals. Then a couple of additional questions about, let's see, there was a question actually about medium chain triglyceride oil. And so, that's a specific therapy, for this particular individual who's asking, it's a specific therapy that is sometimes offered to individuals who have very specific deficiencies, as a method of supplementation. And so with that, again, I would, come back to the recommendation to discuss that with a healthcare provider. There's not a general recommendation that I could give in the setting of pancreatitis. And so I think at this point, we're relatively to the end of the questions here. Anything else from Jenny or the organizers that I might have missed that is important to make sure to cover here?
You did an amazing job. Thank you, Dr. Evans Phillips, and everyone that participated with that in the chat. So thank you so much for your time and sharing information and diving into those questions. A lot to be gathered from this today. And just kind of as a few slides that we'll go through to kind of wrap up, this will be reposted to our YouTube later in the week, and there'll be an email follow-up. But just a few other things to share with you all. We do have many other opportunities to participate with the National Pancreas Foundation. We have the Pancreas Bowl coming up. You could host one of those within your community or with the chapter of your Center of Excellence. We also have another DIY fundraiser, the Color It Purple campaign. If you are not receiving our emails or newsletters, make sure that you sign up for the communications from the National Pancreas Foundation. We also have several galas coming up this fall. These are one of our signature fundraising events, the Courage for a Cure Gala. See if there's one in your community. Feel free to scan the QR code or just visit our website to find more information and to purchase tickets and see if there's one in your area. We also have numerous opportunities to volunteer, make a difference in your community. We host tabling events. There are Pancreas Bowl events, galas, working with the Centers of Excellence and stakeholders in addition to advocacy efforts. So please reach out to us if you're interested in volunteering in any capacity. We would love to have you and see you more often. Also, I do want to share that we have a new Facebook page. We've transitioning during the month of August. So if you haven't, please feel free to add our new Facebook page. Our staff will drop it in the chat as well. But make sure that you find our new Facebook page so you don't miss out. We also post in our emails and on social media all of our webinars that are available for review. And there are several other areas where you can connect with us. So we're on all the socials, do whichever one makes the most sense for you, but we'd love to stay in touch. And additionally, we want to hear from you. What kind of topics are you looking for? What did you take away from today's topic? There's a QR code, there'll be an email follow-up. In addition, there's going to be a link in the chat. So we look forward to hearing your feedback about this event. Thank you for your participation. Again, thank you to Sally and Dr. Evans Phillips for sharing with us today. We appreciate you all joining us and giving your time to the NPF to help make our daily lives easier. Nutrition plays such a huge part of our organization and with our patients. So thank you everyone for your time today.